Welcome to another Grassroots Health, Your Data, Your Answers webinar. Today's topic is diabetes data, questions from scientists. My name is Sharon McDonnell, and I am an epidemiologist here at Grassroots Health. Today, I'm going to give a brief overview of diabetes and our preliminary findings, and then review the types of questions that need to be asked and answered in regard to the data so we can have a better understanding of what's happening. Part of our aim at Grassroots Health is to provide you with some background in public health research and promotion so you can become advocates for and with us. This is where the public needs to lead the way. What we are doing is new, and we need your active and educated support. Please help us with this diabetes prevention promotion with your donation today. You can find a donation link on our website at grassrootshealth.net. According to the Centers for Disease Control, in the United States, diabetes affects 25.8 million people, which is about 8.3% of the U.S. population. And the CDC expects that number to double or even triple in the next 40 years. About 1.9 million people aged 20 years or older were newly diagnosed with diabetes in 2010 in the United States. In 2005 to 2008, based on fasting glucose or hemoglobin A1C levels, 35% of U.S. adults aged 20 years and older had pre-diabetes. Among adults aged 65 years or older, 50% had pre-diabetes. And applying this percentage to the entire U.S. population in 2010 yields an estimated 79 million American adults aged 20 years or older with pre-diabetes. Diabetes is a leading cause of kidney failure, non-traumatic lower limb amputations, and new cases of blindness among adults in the United States. Diabetes is also a major cause of heart disease and stroke. Finally, diabetes is the 7th leading cause of death in the United States. A recent meta-analysis published in May 2013 looked at 21 prospective studies to assess the strength of the association between blood 25-hydroxy vitamin D levels and the risk of incident type 2 diabetes. Approximately 76,000 participants and 5,000 incident type 2 diabetes cases were included. The meta-analysis found that higher 25-hydroxy vitamin D levels were associated with a lower diabetes risk. Also, comparing the highest to the lowest category of 25-hydroxy vitamin D levels, the summary relative risk for type 2 diabetes was 0.62, which translates to a 40% reduction in diabetes incidence between the highest and lowest serum level categories. Lastly, a trend analysis showed that for each 4 nanogram per milliliter increment in 25-hydroxy vitamin D levels was associated with a 4% lower risk of type 2 diabetes. In the newsletter earlier this month, we included Your Data, Your Answers graphs comparing diabetes incidence and serum level distributions in the D-action cohort and the NHANES population. For those of you who may not be familiar with D-action, it is a population study conducted by Grassroots Health looking at vitamin D status and various health outcomes. NHANES is the National Health and Nutrition Examination Survey, which is a program of studies designed to assess the health and nutritional status of adults and children in the United States. The information provided in the newsletter was our first look at the data provided by our D-action participants regarding diabetes. The data presented on the next couple of slides is preliminary and has not yet been published. This graph compares diabetes incidence in the D-action and NHANES study populations. Incidence is the number of new diabetes cases among participants who are considered at risk, which are participants who do not already have diabetes. Among D-action participants residing in the United States, the incident rate for diabetes was 0.9 per 1,000 person-years. And among NHANES participants, the incident rate was 8.5 per 1,000 person-years. For D-action, an incident case was defined as a self-reported diabetes diagnosis after enrollment in the study. And for NHANES, an incident case was also a self-reported diabetes diagnosis, but within the prior 12 months. Since the NHANES questionnaire did not specify between type 1 and type 2 diabetes, asking, other than during pregnancy, have you ever been told by a doctor or health professional that you have diabetes or sugar diabetes? This preliminary analysis determined a combined type 1 and type 2 diabetes incidence. Of note, all of the D-action cases were type 2 diabetes, and since this analysis only included individuals aged 18 years and older, it is assumed that most of the NHANES cases were also type 2, which is most common among adults, unlike type 1, which commonly afflicts children and teens. The rate ratio of the incidence rates is 9.7, which translates to approximately a 90% reduction in diabetes in the D-action cohort when compared to the NHANES cohort, before adjusting for cofactors like weight, age, and gender. Here we see the serum level distributions for the NHANES and D-action study population. On the x-axis is 25-hydroxy vitamin D levels, and the y-axis show the number of participants. The left y-axis is for NHANES, and the right y-axis is for D-action. The two line curves show the serum level distribution for the non-cases in each cohort. The serum level on the x-axis that corresponds to the top of each curve is the most frequent serum level value for that cohort. This graph shows that the NHANES cohort has a distribution of serum level values that are lower compared to D-action. The dots on the bottom of the graph show the serum level values for the diabetes cases. These dashed vertical lines show where the mean serum levels are for each population. The average vitamin D serum level for D-action participants was 53 nanograms per milliliter, and for NHANES participants was 22 nanograms per milliliter. These dotted lines show where the mean serum levels are for diabetes cases. The average serum levels for cases are lower, with D-action cases averaging 35 nanograms per milliliter and NHANES cases averaging 17 nanograms per milliliter. Of note, all but one case of diabetes had a serum level below the average serum level for the D-action cohort. Based on the results from previous research and our own preliminary findings, an analysis of your data could provide a major contribution towards diabetes prevention. In the next few slides, I'll be going over some of the questions we will be asking as we thoroughly analyze the data to assess the relationship between vitamin D and diabetes. One of the first questions that scientists ask is how good is the data? Because your results are only as good as your data. Here at GrassrootsHealth, we have a full-time data manager who meticulously reviews each record for accuracy, which is hundreds of records per month. Some of the things she looks for are data entry errors, such as an 18-year-old that weighs 10 pounds. She also compares subsequent vitamin D test results and questionnaire answers with previous test results and answers to discover unexplained serum level changes and other data inconsistencies. For example, if she notices that a participant's serum level increased dramatically without a change in vitamin D supplement amount, she will investigate changes in sun exposure, indoor tanning, possibly a recent vacation, or season of the test for a possible explanation. Possible data entry errors are found on about 5 to 10% of records, and those participants are contacted in order to verify the data. Some of you may have received a data verification email and have replied promptly, which we greatly appreciate. Another initial question that scientists ask is, what are the inclusion or exclusion criteria for the study population? We will be asking if we will be just looking at adults or including children or adolescents. For D-action, we will be including only those living in the United States in the first analysis to have a direct comparison with NHANES, which only includes U.S. residents. For NHANES, we have the option of using one study year or combining multiple years, so which year we use will be a question considered by our scientists. Since we are interested in diabetes incidence, for both D-action and NHANES, we will be excluding pre-existing cases of diabetes. Another question is, what is the case definition? For both D-action and NHANES, we have self-reported diagnosis of diabetes. The D-action survey differentiates between type 1 and type 2 diabetes, while the NHANES survey does not. However, previous studies have used additional NHANES survey questions regarding self-reported intake of insulin or diabetic pills to lower blood sugar to assign cases to type 1 or type 2, and we will likely use a similar method. Additionally, for D-action cases, we will request medical records for diagnosis verification. Another aspect of the case definition is the time frame for diagnosis. The NHANES study asks about a previous diabetes diagnosis within a specific time period, and the D-action, being a prospective study, collects the date of diagnosis and can therefore look forward or backward within a specific time frame. The next question scientists ask is, what are the confounding variables? A confounding variable is a third variable related to both of the main variables, which here is vitamin D serum levels and diabetes incidence. The presence of the third variable distorts the association between the two main variables, and if not accounted for, it will create biased results. A hypothetical example would be a study of coffee drinking and lung cancer. If coffee drinkers were also more likely to be cigarette smokers, and the study measured coffee drinking but not smoking, the results may seem to show that coffee drinking increased the risk of lung cancer, which may not be true. However, if a confounding variable, in this example smoking, is recognized and adjustments can be made in the study design or data analysis so that the factor does not confound the study results. For our analysis, we will need to account for many possible confounding variables, including BMI or weight, age, gender, ethnicity, latitude, smoking, exercise, hypertension, and calcium supplements. Another important reason to adjust for these factors is that any differences between the D-action and NHANES study population in regards to these factors could have an influence on observed differences in diabetes incidence. In the next couple slides, I will demonstrate the influence of confounders using BMI as an example. These next two graphs about BMI and vitamin D status were featured in our most recent newsletter. Body mass index, or BMI, is a measure for body fat and is calculated by dividing mass in kilograms by height in meters squared. This graph shows the BMI distribution of all D-Action participants aged 18 years and older. BMI categories are on the x-axis and range from underweight, which is a BMI of less than 18.5, to very severely obese, which is a BMI of 40 or more. The percent of participants is on the y-axis. According to BMI, 53% of D-Action participants are at a healthy weight, 29% are overweight, 15% are obese, and 3% are underweight. As a comparison, the World Health Organization reports that worldwide, 35% of adults aged 20 and over were overweight and 11% were obese in 2008. The graph shows that the percentage of participants in each serum level group by BMI category. The green line shows the percentage of participants with the serum level greater or equal to 40 nanograms per milliliter. The orange line shows the percentage of participants that have a serum level between 20 and 39 nanograms per milliliter. And lastly, the red line shows the percentage of participants that have a serum level below 20 nanograms per milliliter. The graph shows that the percentage of participants with a serum level of 40 nanograms per milliliter or above decreases as BMI increases, from 67% for healthy weight individuals to 37% for those that are severely obese. 11% of very severely obese participants have a serum level below 20 nanograms per milliliter, compared to 3% of those at a healthy weight. Since BMI is a risk factor for diabetes, and we can see that increasing BMI is associated with lower vitamin D status, adjusting for BMI will be essential to the diabetes analysis. And as a note, while BMI is a useful measure at the population level, it does have some limitations when applying it to individuals. Another question scientists ask is what statistical procedures need to be conducted. One of the main calculations will be the incidence rate for each cohort, which is the number of incident cases divided by person time. Person time is the sum of the amount of time each participant contributes to the study while at risk, which is the amount of time they are free of diabetes while in the study. We will also need to calculate confidence intervals, which is used to indicate the reliability of the incidence rate estimate. We will also perform statistical tests to test for differences between the D-Action and NHANES cohort, as well as the participants who developed diabetes and those who did not. Additional statistical methods will include determining if individuals with lower vitamin D serum levels had a higher risk or hazard of developing diabetes, and testing for an association between vitamin D serum levels and diabetes incidence. In all these tests, we will adjust for confounders and other risk factors for diabetes. Another important technical issue that we will be addressing is the differences in study designs between NHANES and D-Action. NHANES uses a complex design due to clustered sampling, and D-Action is a simple random sample. What that means is NHANES oversamples certain population subgroups to increase the reliability and precision of estimates for those groups, whereas D-Action's study is most like a random sample, where everyone has the same opportunity of participating in the study. We will need to account for differences in sampling design to minimize bias when comparing D-action to NHANES. After the analysis is completed, we will be publishing the information in a peer-reviewed journal. Briefly, some of the tasks involved in this are conducting a thorough literature review, writing a detailed description of previous research, analysis methods, results, and discussion about the findings and conclusions drawn. We will also be constructing key tables and figures which will highlight the main points of the analysis. And lastly, we will submit the paper to a journal for peer review and publication. All of the steps involved in the thorough analysis, from verifying data to finalizing a manuscript, take many months of full-time effort. Our team is excited to collaborate with our scientist panel of vitamin D experts and get started with analyzing your data. Thanks for joining us today. Please let us know what other things you would like to know about public health research methods and topics. We want to invite you to participate in our analysis by submitting your questions and suggestions in the post-webinar survey. And of course, please help us specifically with the diabetes prevention campaign we have going on now. Thanks again for your participation.